No, it's not asking me to share my password. Enter the password to allow this. Hmm.
Or otherwise, if you share that video with me, otherwise, if you want me to play, I will.
I can share this video to you. I'll send it to your email ID.
Both are okay, sir. Yes, sir. Email or WhatsApp, whatever.
Okay, I think we'll leave that because it's getting time wise.
Okay, sir.
I think we are about to start. We should start. We should start, sir. We should start. We should not wait.
Okay, give me a minute, sir. Just I'll introduce you to the team so that we'll have a session to go on. So, very good evening, all leaders. Today we have a privilege and honor to have our guide and mentor, Dr. Bharat Dave sir from Ahmedabad. So, who is the heading the Stavya Spine Research Institute, and sir is known for his academics and known for his innovative practicing approaches and in spine surgery concerns. And sir is a number one robotic surgeon in India today, and is one among the top 5 spine surgeons in the Asia. And we have a privilege of having sir with us to get ourselves deep dive into the osteoporosis management, right from supplements to the anabolics to the anti-resorptive therapy. And sir has got a very unique approach towards the spine patients, particularly managing patients without surgery. So that is something interesting, and which we are all going to be beneficial with his motto of treating patients in a simplest way. And beyond that, it is also our responsibility to help patients suffering with the serious challenges when it comes to the osteoporosis like issues. And the sir is going to unveil all address his all his knowledge and experience with us. And beyond that, sir has promised us he is going to address all our queries one by one post the session. And sir is open to address your queries even by email if you have any questions post the session as well. As and for our benefit, sir is promised to have one more session if required, to make sure that we are all thorough with this treatment approach and therapy. uh, uh, and beyond that, the today's session, the inspiring thing is the hardworking nature of a Bharat Dave sir of 15 hours daily, which I have inspired from last Misapkan session. And today, whenever I see the sir, I'll remember those words of 15 hours while studying because of the father. And after starting the clinic with the 15 hours working, and started with a single man, and today 100-bed hospital, and the journey is phenomenal. And we have a lot to learn apart from the osteoporosis management. And we request sir to have that session also with us after some time. Thank you, Bharat Dave, sir, for joining us. And the podium is yours, sir. And we eagerly wish to learn from you, sir.
Thank you very much for such a elaborate and nice introduction. Um, First of all, thank you for giving me the opportunity. You can see the T-shirt has got "Do not bend to osteoporosis." So that is something which I want you all to have simple message: Do not bend to osteoporosis. So now I'm going to share my PPT and let us move forward with the presentation. And I request you all to write down all your questions and then email me, or if you get an answer or if you get time. Usually I overrun, so may not get time, but then if we do get time, or I'm ready to pull on for long as well, if you all are ready. So I have written tackle two monsters. Two monsters are, one is osteoporosis and second is sarcopenia. Sarcopenia is something which is related to the muscle mass loss, and osteoporosis something related to the bone loss. And both are very important for our body because they are the hidden monsters in our body. So, how do we really tackle them? Can you really tame them down 100%? Perhaps not. And that's why I've written 18 to 80. And let us learn together. These are my disclosures. So, and this is the new hospital. Now, I would just like to say only one sentence about couple of things which I have written here. One is the Lord Krishna. He was the first eternal spine surgeon who corrected the deformity of Kubja, and I have nominal aphasia. So if I bump into me tomorrow and if I do not remember me, or if I do not know call you by your name, that's me, because I most of the time forget. So that's my nominal aphasia. That's what I accept that as well. Now, do you know what is osteoporosis? Perhaps you all know that. I'm sure you all know what is sarcopenia, which I just mentioned, muscle mass loss. And I'm sure you all know how to use teriparatide as well, but I will share my experience. And same as denosumab and perhaps decadurabolin as well. So I'll share my little bit of experience about decadurabolin as well. I'll start with this prayer. Om Sahna Vavatu Sahnau Bhunaktu Sahviryam Karvavahai Tejasvina Vaditamastu Ma Vidvishavahai. Om Shanti Santi Santi. So the essence of this slok is we work together with great energy. And that is something which we are all together today on this day of Ram Navami, which is one of the most auspicious day, and that is what is going to give us the best energy as well. I'm sure you all will agree to this, that Ram Navami is the day today, the ninth day. Now, love me or hate me, but think about me. And what is that? Osteoporosis and sarcopenia. Diabetes and hypertension, we know that they are the age related disease, and we know that that is something which we cannot prevent as well. If it is coming, it's going to come. But at the same time, we can very well reduce the incidence, or we can very well reduce the complication rate. So once diagnosed, it's a lifetime treatment. For same is true for diabetes, hypertension, and osteoporosis. Drugs have different actions. So we will be talking about both teriparatide and osteoporosis, denosumab, the treatment for osteoporosis. And we will talk and elaborate about the sequential therapy, which is the most important part of today's talk. So learning objectives are, it's a phenomenon which is going to be regular evaluation is required, and it's aging. Once diagnosed, lifelong treatment in each drug has got its own time frame. So I would go down to the previous slide. Presentation is the information about how we manage fragility fracture at severe. So that is very important. We all know what is osteoporosis, defined as a systemic skeletal disease which is characterized by low bone mass and microarchitectural deterioration. And that leads to fragility fracture and related to the fracture risk as well. Now, if you know, or if you do not know, I really need to share the information. At the age of 35, we have maximum bone mineral density. And as the age increases, 1% per day, 1% per year, the bone mineral mass goes down. Meaning what? At the age 70, our bone mineral dose is nearly as low as 35% to 50%. And in the particularly in the postmenopausal women, it is even more. And when we all adult, particularly the age male patients, then the bone mass goes down up to 75-80 because of the andropause. So everyone knows about menopause, everyone knows should know about the andropause as well, which is the male menopause. We all know WHO definition, when the T score is less than minus 2.5, we call this osteoporosis, and osteopenia is -1 to -2.5. This is the most important slide. What happens that the bone remodeling occurs. The bad cell is osteoclast and good cell is osteoblast. Osteoblast is the cell which lays down the bone. Osteoclast is the cell which eats the bone. Now osteoclasts need to prepare and make the pit for the osteoblast to act, and osteoblast gradually lays down the bone. So this is the constant process which is going on in the human body. Osteoclast is eating the bone, osteoblast is laying down the bone. So it gradually lays down the bone as well. So in order to elaborate, this is something which I can show you how it happens. So these are the osteoclasts which are eating the bone and then keep eating the bone. And this is the cellular mechanism. And now the osteoblast will come and gradually lay down the bone. So these are the osteoblasts. They are the good cells. So you can say Britishers were the bad cells which took away all the good things from India, and Indians now gradually have started laying down. So that's osteoblast. Now this is what happens at young age. When we become old, this is the scenario. So osteoclasts keep eating the bone. And the osteoblasts are not as many. And osteoblasts, they keep laying down the bone, but not enough to lay down the bone. So it takes time for them to work, and it weakens the bone architecture. And as you can see, the bone architecture is not as normal as it was earlier. So this discrepancy is we need to address, and that is why we call this osteoporosis as the silent thief. It eats the bone, and the bone laying down does not occur as normal as it should. So imbalance occurs as age increases from osteoblast to osteoclast. Osteoblasts are not strong enough, and osteoclasts, they keep eating. So BMD changes as you can see with the age. At the age 35, it is maximum. In the men, it starts reducing, but in the women, it declines very fast. This is the BMD, and this is going to happen to everybody. As we develop presbyopia at age 42, who is going to escape from this? Nobody. We all have the gray hair. Who is going to escape from this? Nobody. So age cycle is something which continues. So time is something which we cannot stop, and will keep on gradually eating the bone, and BMD will reduce, and hence microarchitecture will also be not strong enough to sustain a small fall, and the fracture will occur. And similarly, you can see the incidence of hip fracture and what happens to the women and what happens to the men. So this is something is a fracture incidence as well. So this disease earns the bread and butter for us. See, this is on the sarcastic side, but provided we should be addressing to its maximum so that we can reduce the suffering of ourselves, our society, and our patients. So we really need to know about this, and this is something where effect of osteoporosis hip fracture will reduce the mortality, and 8% male and 3% female lead to mortality. This is 6 months. So this is quite high number. 63% in men and 74% in 12 months. So that is again, in 6 months, 8% dies, but 12 months, 63% and 74%. So after one hip fracture, it becomes a deathbed. Can we prevent this? Yes, we can. And morbidity, again, not able to walk 50% independently. So after the hip fracture. Same thing is 86.5% mortality 12 months. So somebody who gets the fracture of the spine, the mortality at 12 months is 86, very high. So this is something where we can chip in and we can address the quality of, improve the quality of our patient as well. And back pain and kyphosis, loss of height. So these are the US FDA approved drugs which are available. I'm sure you all are aware of it. And there are two groups. One is anti-resorptive and second one is anabolic. So teriparatide falls into that anabolic group. And recently we have now available romosozumab in our country as well, which you can say that's an osteoanabolic. Abaloparatide is not available at the moment. The anti-resorptive groups is bisphosphonate, denosumab, calcitonin, estrogen and estrogen antagonist raloxifene. Now, we call this as silent tip and we compare this with termite. It eats the bone. So as you know, it erodes the wood inside, the termite. We never know when it enters. It preserves the outside architecture and it eats from inside and it crumples from inside. And if you really want to, the minute you open the cupboard, the whole door will come out and eaten away. The termite would have eaten away the whole cupboard if it is not, used regularly. So that's the termite which does the damage. Similarly, the osteoclast, they do the termite work and they eat the bone away. So this is very important. So look at this female, 58, her photo, which she was kind enough to give me her photo. There is no gimmicks, there is no magic in this. You can see what happened, her height loss. What happened? Her height loss. Just imagine, the last photo which is on the right side is the last photo when she came to our clinic. And she was able to give me the previous photos of her and her husband. So you can see the height loss is something which was a silent episode in her case. And why? You can see 2007, 16 September, there was only one vertebra fracture. 2010, there were 3, 4 vertebra fracture. And 2019, she had severe kyphosis because of the multiple wedging of the vertebra. Can we prevent this? Yes, to a great extent by awareness. And that is why we are here today for awareness, awareness, and awareness. We will talk about this awareness as we go along. How do we make it more and more? The only way to diagnose is the height loss. So many a times in my talks, which I tell to everybody, that now you start recording the height after 60th of your birthday. For a female, 50th of their birthday. Put it behind the door and every year you check. Height loss is first sign, which is a silent sign. And as we know that osteoporosis does not have any symptoms or sign. And you see the fracture which has occurred silently as well. The other diagnostic tool is the DEXA scan, which is available nowadays in many places. And that is something which will help us in diagnosis and the treatment response. So DEXA scan is not just to diagnose, but also to see the treatment response as well. So management of osteoporotic vertebral fracture, you can say all kinds of things. We really need to investigate. We really need to go for the basic investigation. We really need to investigate the secondary cause of osteoporosis as well. All these things are all written and standard protocol to be followed. And there are FRAX score available as well, which is available on the net. So if you write down FRAX, fracture risk assessment tool, and this will give us the assessment in next 10 years what is the incidence of the fracture risk. So this is easily available and it is available on the net. So that is something which we use as well and which we recommend all of you to use after the age 50 for female and 60 for male. And these are the things which we carry on talking about, the clinical risk factor. So this is basic, this is for your knowledge. When do we consider clinical risk factors? Are BMI more than less than 19, previous fracture in the family, parent, rheumatoid arthritis, patients on glucocorticoid medication, and those who take alcohol and those who have the smoking as well. They are the risk assessment, it increases. Now look at this 55-year female, had severe back pain, but then her diagnosis was parathyroid adenoma. I will be talking about parathyroid gland at many places. So that is why I have put this slide for you all to know. As we know that there are two types of the gland in the neck, thyroid and parathyroid. Thyroid is in the center, which has got on the back of it. There are parathyroid glands which are available, which are there for the calcium metabolism. So these are the parathyroid glands. And this patient had parathyroid adenoma, which gave the osteoporosis. So that is why I will be talking about this. You have to have PTH checked, parathyroid hormone level checked. This is the Frex which I talked about. This is the machine which is DEXA machine which is available, and we can get the DEXA easily, which is not an expensive tool, around 2000 to 3000 rupees all the centers they charge. So principles of DEXA, we all know that it is something which is not for back pain, but it is for diagnosis and fracture risk assessment. And women age more than 45 in our country after the menopause, men more than 65 in our country, and that is where we should be getting the DEXA scan as a baseline tool. And we know that these are the information which it gives, and baseline DEXA report is very helpful. Now, follow-up DEXA, when do we do? If the DEXA is positive, when the DEXA scan it is less than minus 2.5 or below, then we advise to repeat DEXA every year. When the DEXA is in osteopenia phase, then we advise to repeat DEXA every 2 years. So that is very important. With the clinical risk factor, if any of them you have, then that is something where we should be checking every yearly. DEXA scan, I repeat, it is not for back pain diagnosis. It is mainly to diagnose the osteoporosis. So this is something which is the historic management of osteoporosis discoveries. So when was the molecule diagnosed, or other calcitonin, PTH? So bisphosphonate were used, or rather are in practice since 1994, and IV bisphosphonate was available in 2004. PTH anabolic available since 1998. In our country, I have been using this anabolic PTH since last 15 years. And 2006 PTH plus zoledronic acid combination treatment, 2008 denosumab was introduced, 2012 PTH and denosumab combination therapy has been introduced, and 2014 data and data extension studies, they proved certain facts which I will be sharing as well. And 2019 the romosozumab now is available in the market in India. So that is something which is now, who is at low risk, T score, high risk and very high risk. So this is very important, where we should be advising teriparatide or denosumab, both or combination, that we'll share again. So T score, medical condition, osteoporosis risk factor, but somebody who already has got a prior fracture, they fall into very high risk. And that is where we really need to prescribe the combination therapy or follow-up treatment to continue regularly. Low risk, reassure them, advise, consider HRT, and some. High risk, start antiresorptive, but very high risk, I repeat, we should be giving the anabolics, and that is the teriparatide, which is available in our Indian continent. This is very important. I put this time bomb. So what is time bomb? Suppose patient comes to us with a fracture. Suppose somebody who comes to us with osteoporotic vertebral fracture. Now I call this as a time bomb theory, because if we do not act in the first 3 months of that fracture, fracture will collapse and it will give rise to neurological deficit and deformity. So in first 3 months, we usually start teriparatide and we educate the patient. We advise them to restrict their activity, lifestyle modification, and we advise them to be very vigorous about the management of osteoporosis, because first 3 months are very crucial, and these 3 months, they are the one they should be addressed to its maximum. And that is where we advise them to go for the reports, the blood test, and then we start therapy according to the blood test. Now coming to monotherapy. We will be talking about monotherapy, meaning only teriparatide, only denosumab, or only romosozumab. So what do we say here? Osteoporosis. How do we treat them? Teriparatide from 18 to 24 months, that is an ideal duration. Romosozumab for 12 months. Denosumab, current data available of denosumab 10 years safety. I'm sure soon we are going to get the 15 years safety as well. Bisphosphonate, we give it for 5 years, and after that we stop for 1 year, and then we restart again, because we do not want the atypical fracture to occur. And obviously calcium, metabolism and vitamin D, they are the one we should be giving regularly to all our patients. That's a base pillar. So teriparatide, what is it? It's something which is anabolic drug which stimulates the bone formation and it enhances before it leads to the bone resorption. It is the only molecule which is anabolic available at the moment, and it is something which is the anabolic window. We will talk about that in few slides, in coming slides as well. So teriparatide, it is a molecule which is positive part of it. It is osteoblastic stimulation. As we saw in the video, it stimulates the osteoblast. So it is the only molecule which is available. It stimulates the osteoblast. Currently, romosozumab is thought to be stimulating the osteoblast, but that we do not have romosozumab, so we won't talk about that. We will talk about teriparatide. It is the only drug which improves the bone architecture. So bone is cortical, which is outside cell, and inside is the cortical cancellous bone, which is the like the mosaic. So that one also keeps on increasing as well. So it improves the bone architecture, trabecular and cortical. We call this as a miracle molecule. Why do I call this as miracle molecule? Because when I started my practice as spine surgeon, because the workload which we have, we used to put cement about 10 to 15 in a month, vertebroplasty cement. After I started using the teriparatide, our cementing rate has gone down to practically zero, 1 to 2 per year. So just imagine the scenario which has changed because of this molecule. And this is the data. I do not remember when we cemented somebody in the last, 1 year. So that is something which is miracle molecule. It changes completely bone healing, bone pain disappears after we start teriparatide. What is the negative side of it? Well, it is a parenteral. You have to give subcutaneous. It's a cost. Sometimes the cost is quite prohibitive. Limited duration. You have to give it for 18 to 20 months, 24 months, and it is once in lifetime. Compliance is adherence to the treatment. Many a times patients do not adhere to the treatment, and that is where the compliance is relatively less as far as the teriparatide is concerned, because you have to maintain the cold chain. Now that is where I would put a caveat as well. The cold chain has to be maintained in order to have the proper drug outcome, proper drug effect. And biosimilars are available, as we have one of them. And that is why sometimes, I say that apple and orange may not be the same. This is most important. Now, you know that teriparatide, it is paratide chain, half of the chain of the PTH, parathyroid hormone. So half of this chain is used to stimulate the osteoblast. Now, if somebody is hypothyroid, somebody who is diagnosed to have hypothyroid, we keep checking their thyroid level, isn't it? We go for the TSH, T3, T4 evaluation. So how can you start a parathyroid hormone without checking PTH level? So this is something that we have to tell to all consultant, that you have to get your PTH level checked, our patient PTH level checked. This is most important. We should not be advising anybody to start PTH teriparatide without checking the PTH level. PTH can be because of the primary hyperparathyroidism. That is where on my previous slide, which I have shown, that in the neck, the parathyroid gland was highlighted. So that was something which led to the osteoporosis as well. So if you give teriparatide in a dose which is like, pulse dose, then it stimulates the osteoblast. But if it is continuously delivered, then it gives to osteoporosis. Let's not debate on that, because it will be out of your syllabus as well. But I repeat, the PTH level has to be checked, serum calcium level has to be checked, serum alkaline phosphatase level has to be checked before we start teriparatide. This is bottom line, because we want to rule out primary or secondary hyperparathyroidism. Secondary hyperparathyroidism may be because of vitamin D low, serum calcium level could be low as well, and they all can lead to hyperparathyroidism. And when there is hyperparathyroidism, you should not be giving teriparatide. I'm repeating the same sentence again and again, because that should be percolated to all the consultants when you go and introduce this molecule in your MR call. Malignancy. This is the contraindication for teriparatide. Why? This should go in your head as well. Teriparatide stimulates parathyroid hormone, the receptors. And this receptor have been found in many malignant cells. So a malignant cells may have parathyroid hormone receptors, and this molecule can give rise to sudden increase in malignancy. This is again theoretical, not proven everywhere, but this is something which is recommended by the original innovator. So that is why I repeat, serum calcium, serum PTH, vitamin D, alkaline phosphorus level for the blood test, and malignancy is the contraindication for teriparatide use. Bisphosphonate. We all know bisphosphonate commonly used. It reduces the bone density, but then it improves the bone density, and it is the osteoclast, the British cells, the bad cells. They are killed. They are this particular bisphosphonate molecule. It adheres to this osteoclast and it kills that osteoclast. Apoptosis of the cells occur. But then this is little bit negative as well, because osteoclasts are required to some extent to have the pit, to form the pit, and the pit formation stimulates the osteoblast. So that is again little bit of discrepancy here as well. So we should be using bisphosphonate, and after 5 years we should stop for 1 year. No point in giving bisphosphonate for 3 months and stopping for 1 year, because the osteoclast, the molecule adheres to osteoclast and it does not go away that fast. So compliance has been an issue with that as well, but not that issue. Positive aspect is cost effective. One can give IV as well now, zoledronic acid, and drug holiday is must after 5 years. Osteoclast apoptosis, creating chronic renal failure. So we should be giving them with due care. So that again become relative contraindication for the use of bisphosphonate. Negative side, it suppresses the bone turnover. It can lead to jaw necrosis, osteonecrosis as well, and sometimes patient compliance. Gastric, once you take it from the oral medication, bisphosphonate, you have to keep walking. You cannot lie down because it can give rise to regurgitation and it can give rise to esophageal ulcer. So after taking bisphosphonate, one should not lie down. And the yearly zoledronic acid is available as well, and drug holiday. Denosumab. This is something which is rank ligand inhibitor. It suppresses the osteoclast differentiation and activation. So again, it is acting on osteoclast, anti-resorptive molecule, and it is to be used for the osteoporosis when it is not in the high risk, moderate risk, or the low risk. So positive part, once in 6 months. This is the best part. Patient compliance is very good with denosumab. Current available is 10 years. I repeat, 15 years will be available soon. No major lab tests are required for that. You can give it. It can be given in malignancy. It increases the BMD faster. The negative side, every 6 months, if you skip the dose, the new fracture will occur. This is the most important negative side of denosumab. So I see investigation, I see the prescription, one dose only. You cannot do that. So once you start denosumab, it has to be given for 10 years. If patient misses the dose, refracture will occur, and that will lead to another refracture. Patient will lose the confidence in therapy, in doctor, and in treatment. So that is something which he cannot afford. So that is very important, denosumab. If it is not followed regularly, BMD will reduce. It is injectable, subcutaneous, and again patient compliance and adherence has been found very good with this molecule. So this is the best part of this denosumab. If patient stops denosumab, we should start bisphosphonate, either injectable or oral. So I will share the studies about the same as well, why I keep insisting about the denosumab. This is decadurabolin, which we extensively use for sarcopenia and osteoporosis both. It improves the both muscle mass and the bony architecture. This was the study which we did. It's been published in two journals, Indian Spine Journal and Curious. Now coming to monotherapy. So this is something where you can see that the reduction in the hip fracture occurs, non-vertebral fracture occurs with this as well, and very important. So we really need to keep learning about monotherapy, and that is where it really helps in improving and reducing the fracture as well. Romosozumab again it improves as well. Now effect of discontinuation of zoledronic acid. This is very important. So the bone mass increases but does not drop that fast. This is very important when you have given zoledronic acid. And bone mass does not drop suddenly after stopping this. So this was after 5 years of stopping the zoledronic acid or bisphosphonate. Now, this study, again the alendronate, oral alendronate, it kept on increasing and it did not drop that fast. So this is a flag study. This is a flag study as well. They have put this PIT study. So these are the name of the studies which you can go into the Google and read about it if you are interested. But basically what I am trying to convey, discontinuation of alendronate does not drop the BMD fast. But if you stop discontinue the teriparatide, then there is significant decrease in 7.1% and 4.1% in the man. And at the hip and femoral level, 3.8% and 3.1% for the man and women. So basically what I am trying to convey that out of 100, 7 patients will have BMD drop after discontinuing teriparatide. So that is why we have to switch over from teriparatide to sequential therapy, which I will cover in coming slides. So discontinuation of teriparatide alone will lead to fracture, and that is why we have to continue the second molecule. Similarly, denosumab, look at this. It has been given, then sudden drop occurs. So that is why this is the study which was effect of denosumab treatment 2011, and this was done in published into endocrine journal. So sudden drop of the hip and spine after stopping the after the 24 months. So this will lead to new fracture. So friends, if at all we request all our consultant to start denosumab, please request them continue it for 10 years, sir. Do not stop in between. If patient compliance and patient adherence is a question, do not start. If patient compliance and adherence is good, then start. Or tell them, inform them, stop it. If you do not want to continue it, then come and see me. We will switch over to zoledronic acid or bisphosphonate. This is very important because the osteoclast will start eating, they will flourish and they will eat the bone, and new fracture will occur on 8th or 9th month of stopping the denosumab. So except bisphosphonate discontinuation, all the medication used to treat osteoporosis is associated with rapid loss of bone mass. So that is why teriparatide and denosumab has to be continued with second line drug. Now coming to combination therapy, give 1 plus 1, denosumab and teriparatide. Can we give both together? Yes, one can, but then the effect is not 1 plus 1 is equal to 2. So we should not be advising this because it increases the cost of therapy. Now look at this teriparatide denosumab given, and you can see that this you can take the snap and then you can read through, but I have put this as an evidence that teriparatide and denosumab analysis was done, and then there was no major difference if teriparatide only was given. So adding denosumab with teriparatide does not increase that BMD fast. Similarly, zoledronic acid and teriparatide same way does not increase the BMD fast. So combination therapy should be evaluated properly, does not seem to have effect 1 plus 1 is equal to 2, and it just adds the cost. So if a consultant is advising that, yes, in a high risk group, you can. Even if 20% improvement occurs with combination therapy, we should. Now coming to the learning objective. So our learning objective was each drug has got time frame. So time frame for the teriparatide was 18 to 24 months, denosumab is 10 years, and zoledronic acid or bisphosphonate or alendronate has got 5 years. So this is the anabolic window I was talking about. Sorry, huh? So PTH acts as PTH receptor and it gives good 2 months, 2 years. Then the anabolic window stops, So that is where we should be switching over from one molecule to other molecule. So this sequence of bone formation and resorption leads to anabolic window, which is the period when teriparatide shows maximum anabolic effect. So that is why anabolic effect you achieve for after 3 months, then it continues. So request the consultant to do not stop teriparatide after 3 months. Many prescription I see teriparatide for 3 months and then they never get the follow up. So if at all you start, again teriparatide has to be continued for at least 12 months, maybe 24 months is ideal. So we should be requesting all the consultant to continue teriparatide for 24 months. That is anabolic window. So bone formation is at its maximum and by the time we switch over to sequential therapy. So now coming to sequential therapy, which is the second agent which we treat for osteoporosis. I repeat, osteoporosis once diagnosed, it is a lifelong disease. And this lifelong disease is something which has to be, this monster has to be tamed down. So if needed, many patients, they should be given the therapy and one after another. So now coming to my previous slide, if you have seen that, so teriparatide to bisphosphonate or teriparatide and romosozumab to denosumab. This is an ideal sequence to follow. And obviously oral calcium vitamin D has to be continued. So that is combined therapy or the sequential therapy which is shown here by these two arrows. So that is very important. So once teriparatide, that is anabolic, osteoblasts are stimulated, they have increased the bone architecture and osteoclasts need to be suppressed after stopping teriparatide by either bisphosphonate or denosumab. I repeat, combination therapy 1 plus 1 is equal to 2. That is not true. So we should not be advising that, but we should be advising after we start anabolic, that is teriparatide, either we start to bisphosphonate or denosumab. So teriparatide, we repeat, molecular molecule, calcium PTH has to be done, bisphosphonate, as we repeat, combined therapy does not have additive effect, and this is something which is very important. So take home message, osteoanabolic agents are preferred in the initial treatment for high risk and severely high risk patients as well for the fragile fracture. Sequential therapy, now this is very important. Anti-resorptive agent should be followed by anti-resorptive. So denosumab is anti-resorptive, should be followed by zoledronic acid. Anti-resorptive agent to be followed by anti-resorptive or anabolic. Well, this is where the loss occurs. So suppose somebody who is on denosumab therapy, listen to this carefully. Somebody who is on denosumab therapy develops the fracture and consultant decides to start the anabolic teriparatide. If the teriparatide is started, initially the bone loss occurs and patient develops the fracture. So this group of patient should be protected, meaning either they use a walking aid or stick or belt. I'm repeating the same sentence again. Somebody who is on denosumab therapy and while they are on denosumab therapy, the fracture occurs. So we as a consultant tend to start teriparatide in order to fasten the process and bone stimulation of the osteoblast. So if the osteoblastic activity, if you want to stimulate, what you need is osteoanabolic agent, and that is teriparatide. So if you start teriparatide when the patient is on osteoclastic suppression, meaning denosumab, the patient usually develops fracture because of the cellular mechanism is lost. Cellular mechanism is disturbed, and that is where we need to protect this patient for initial 2-3 months because the new fracture will occur. So this is very important. Anabolic therapy like teriparatide has to be followed by anti-resorptive. Anti-resorptive therapy followed by anabolic therapy, that's a red flag. So all these studies have been done and I have shown you, I have given you few data as well and another data comes here as well. So all this is all studied done previously by in the Western world and that's what we normally follow as well. All these things has been elaborated very well in these studies and the take-home message, transition from bisphosphonate to PTH analog could result in transient loss of the bone BMD. I repeat the same sentence which I elaborated twice. So osteoanabolic agent are preferred in the initial treatment followed by the other anti-resorptive. Anti-resorptive agent followed by anabolic. Again, the study shows that denosumab followed PTH, rapid bone loss occurs and that's where we need to protect them. So these are all studies which are all mentioned as well. Now coming to the anabolic followed by anti-resorptive, and that is where you can see that significant amount of the reduction in the rate of the fracture. So this is very important. So that is why we always prefer anabolic first followed by anti-resorptive. So in summary, most of the patient with osteoporosis require long-term therapy. I would say lifetime therapy. In severe osteoporosis, presence of fragility fracture, strongly we should consider the osteoanabolic agent. So high risk patient is somebody who has got the previous fracture and new fracture occurs. Except bisphosphonate, rapid bone loss occurs on discontinuation of teriparatide or denosumab. So this is very important. Transition from teriparatide to bisphosphonate results in the loss. So that's why we really need to prevent them. Avoid transition from denosumab to PTH, which I mentioned, and avoid treatment from denosumab for 3 years, at least more than 3 years, young patient. So somebody who is young, we should avoid giving them more than 3 years of denosumab as well. So these are the red flags should be highlighted when we introduce as a pharma company to a consultant that these are the red flags for the denosumab. So tailor-made treatment. Now coming to sarcopenia. This is few slides only. So at the age 80, we would have lost the 60% of the muscle mass. At age 60, we have lost 25% of the muscle mass. So outside architecture will look the same, but muscle mass is lost. And that is the second monster which we call as sarcopenia or silent sucker. It sucks the muscle. So silent thief is osteoporosis and silent sucker is sarcopenia of the muscle. And you can see outside looks normal at the age 25. At age 60, you can see the muscle mass has lost and the fat is there. If you look at this MRI of the spine, this is what the spine looks like. And look at this. The muscles which are normal, they are infiltrated by the fatty tissue. So no wonder why patient develops the fracture by simple fall or muscles are lost. If you look at this psoas muscle, look at the psoas muscle here. If you look at the paraspinal muscles of the back, look at the muscles here as well. So they have lost their normal architecture. We call this as sarcopenia. So sarcopenia and osteoporosis, they are the two monsters in our body. They work together and they try to tame us down, and both of them will lead to fall, fracture, morbidity, and eventually mortality. And to a great extent, we can improve the quality of life with the knowledge which I have shared with you. And for the sarcopenia, what is most important is vitamin D, second is protein, and third is activity. So muscles, you can train them with the low weight, low impact exercises, and that is how you can keep them building up as well. So this is the one which we have seen already. So sequence of osteoporosis therapy, anti-resorptive to anabolic. Ideally, one should not do it. It delays the anabolic effect. Anabolic to anti-resorptive, that is ideal. Anabolic to anabolic, well, it will give the neutral effect. But anti-resorptive to anti-resorptive, it again gives the good outcome. So anabolic to anti-resorptive is ideal. Suppose patient is on anti-resorptive like denosumab, it should be followed by zoledronic acid or alendronate. So these are the sequence one should follow. This is most important, which we practice in our hospital. So if I start denosumab or if I start teriparatide, I make the patient take the pledge that you take the pledge that I will not stop without my advice. And most of the patient, I make them understand that this is the molecule which is most important for you. It is to improve your quality of life. It will take your, save your money because you do not need to have the fracture surgery done because your bone is restored well. So we make sure that they take the pledge and they go out of this room with full understanding. We have got the books as well written on the same. So if I can. So this is what, at the end of the day. So we advise to take the pledge and we advise them it is diabetes and hypertension like disease. Secondary prevention care, which is very important. This condition is underdiagnosed, undertreated. Once fragility fracture, second is on its way. This is the most important sentence which we should be highlighting to all our patients. Suppose as a medical rep, you are advising them to start teriparatide. So we advise them, madam or sir, please remember this. Osteoporosis is a lifelong disease like diabetes and hypertension. One fracture has occurred, second one will occur if you do not take the regular treatment. And the way we advise, one eye has got the cataract, second eye is likely to have the cataract. All the bones were born at the same time. One has fractured, second one, why won't it fracture? So you really need to prevent the second fracture occurring. And how do we prevent that? By giving you the medication. So please do not, for the God's sake, do not stop the medication. And if at all you want to stop the medication, go to your consultant. And the way we or MR as a representative, we should be talking to the consultant as well that these are the small things which are must. I repeat, for teriparatide, PTH level, calcium level, vitamin D level has to be checked and no malignancy. That is PTH, teriparatide. Denosumab, once started, has to be continued for 10 years. If patient compliance is not good, then we switch over to another anti-resorptive like alendronate. And calcium vitamin D has to be given regularly with to all our patients. Pharmacotherapy is a mainstay. Available drugs, we all know that. Several drugs, several issues are found. Lack of awareness by the healthcare provider and patients, which is very important. And poor adherence to the therapy, it is something which is safety in the long term. It is safe. Patients, they come to us and say, you are advising me for 10 years. Is it safe? We write down. The 10 years denosumab, it is safe to take every 6 months. Do not stop. Many patients now, currently we see patient traveling abroad. Now, how do you circumvent that? So we advise them, if you are traveling abroad, you take the drolendronic acid, IV, 1 year, or you take oral medication with you. So after that, you can switch over to, after stopping denosumab, 6 months are over and you cannot get the denosumab second dose, you switch over to this. But if you do not continue, as you have taken the pledge, you will get the second fracture. So this is very important. So general health, type and level of neurology, degree of osteoporosis, deformity, all these are very important to plan the treatment. Osteoporosis is a medical disease. We have been seeing this resistant osteoporosis. Means anything that you give, it does not work. So this is very important. So we usually advise them to, have the regular follow-up. So what can we do from our level? We should plan the studies, the Indian scenario. What I have narrated all are Western studies, and I'm ready to share there's all were the sponsored studies as well. So please do not take this as a negative comment, but they have the data and we are working on that data. So if we have the data of our own studies, we can be, robust. We can say, okay, 1 year or 6 months or 12 months or whatever. So we need to really come to our country and we really need to have this science and evidence to follow. Our country is unique. As we all know, being Indian, everybody would like to say, oh, we are Indian. If you look at any cricket match, before playing, all the Indians, they will stand up erect and straight. While all other countries, they will have friendship. So our country has different discipline than other country and the Western world. So our discipline is completely different. We should be following that. Our people are unique and our mindset is also unique because we know that doctors prescribe 3 months of 3 doses of denosumab. Then after that you forget. Well, why do we need to do that? So that is where we lose our patients. We have the new fracture. Our society suffers. So that is where the business and science need to work together. And what I have shared is just my experience. Sometimes I see 3 discontinued denosumab patients in a day who has a new fracture. And I'm not exaggerating by my words. We have the data of 3 lakh patients which is on board in our computer OPD patient. And we have operated around 27,000 surgeries as well. So that's the severe data which we have. So my moments are, please do not have 3+1 supply. Don't take me wrong again. I'm here to share because somebody whom you have supplied 3+1. So 4 vials are supplied of teriparatide. The fridge of that patient may not be working properly. The fridge may not get the electric supply tomorrow. It may not have the continued electric supply where the drug will become water. Sometimes the side effect occurs because the skin reaction occurs with teriparatide, may not be in the pure form. Then patient will ask you to take it back. and you take it back with gracefully and you supply to somebody and may not be adequately stored in the ice bag. So please let's not have that, because that teriparatide is not going to give the same desired effect which a new vial would have given. So please do not say that. You take the money for 3 plus 1, you charge that I am giving you 3 plus 1, but then supply each month new vial. Don't supply 3 vial together or 4 vial together. And so from company perspective, I request you to please do this. So let us follow the science. Let us educate. Let us have the pledge. Let us give and get the best to our society. And Denosumab, do not miss the dose. So this is something which we do it in a different way. You know, how do we educate our patients as well? If this plays, then I think will be good. So it is the young India, and we have this 3-minute video. So we do this drama on the stage. All our hospital staff is there playing this. Osteoclast are the Hindustanis, and you can see the model which is there. The audio I could not play, but you know these are the things which you can see at the bottom line. Osteoclast are the Britishers, and they have come, and menopause. So they will eat the bone away and will lead to fracture. So osteoclast, they have eaten the bone and it has given rise to fracture of the vertebra. So now Gandhiji comes and he is unhappy because Britishers have taken away, osteoclast have done the damage to the body. It's playing. Okay. So basically at the end, osteoblast, they kick the Britishers out and by killing the osteoclast. And that is where, we can, in the drama, it becomes a peak at the end that the Gandhiji comes with the stick and, kicks out all the Britishers. So osteoclasts are suppressed and osteoclasts are kicked out. So this we can play as well. If you all want to have a drama, we can do in one of the nearby hall, which we did it in the Tagore Hall and in the medical Ahmedabad management hall as well. So coming to last few slides, treat the person, not just the bones. The good physician treats the disease. A great physician treats the patient who has the disease. So we really need to look at the other sides as well of the disease, meaning somebody who has liver disease, somebody who has malignancy, somebody who has renal failure. They are the different ball games for management of osteoporosis. So a great physician treats the patient who has the disease with the multiple comorbidities. That was Sir William Osler. The basic purpose of life and education is to enhance one's boundaries of perception. Teaching should not be a profession, it should be a passion. Only then education moves from imposition of facts to exploration of the truth. And this is our operation theater. We have technology, technique, and talent integrated in our operation theater. This is our fourth edition of osteoporosis book. First, second, and third edition, which we already had, and the fourth edition, which is already there. Gujarati version will be coming in just 2 weeks. So only patient education, and we can have the hard copy. This is my email ID, brd_172@yahoo.com. So if you really want the book, I can send it to you, which is in English. You can send me the address or the email ID, and I can send it to you as well. And coming to 5 doctors went on a duck hunt: GP, pediatrician, psychiatrist, surgeon, and a pathologist. So GP saw the duck, but then he wasn't sure whether it is duck or not, so he did not shoot. Pediatrician wasn't sure male or female duck, and so he did not shoot either. Psychiatrist, he wasn't sure whether it is duck or not, so he did not shoot either. and surgeon should bloom and then ask the pathologist to see whether it duck or not. So as a surgeon, sometimes we do these naughty things. We do something which we should not be doing. So that is the message I want to give. As a human being, we do something which we should not be doing. So please beware of this. We should be treating the condition with all the proper guidance. I think the video is playing. Let me see if I can play and so Britishers have come. I think we stopped somewhere after this. So Gandhiji comes and he is unhappy. Now we are treating the osteoporosis and Gandhiji comes back and comes with this. So thank you very much. Over to you, sir. Vasu, Mr. Vasu, and I'll stop sharing.
Thank you so much for enlightening us, sir. So such a wonderful involvement in making the people to understand about osteoporosis. Today we are learning, but what you have done for so many years, it is something that we have seen in your presentation. So kind of drama, all these things, like the message is simply reached to the even general public.
Yeah.
We can organize such kind of event, one for a children's or something like that, so that that message will be there for next one generation kind.
Yeah, I think good that you have shared about these children. So
Hmm.
we sometimes consider osteoporosis as a childhood disease.
Okay.
Why do we use this word? I did not put the word bone bank because if you put the bone bank word, then it has got a lot of meaning in it. Bone becomes strong when we load them. So, lot of awareness is going on in the society about strengthening the bone by weight bearing exercise. So, if you have the weight bearing exercise, BMD increases. So, by the age 35, we really need to everybody that your BMD should be more, your BMD should increase to a level. When it starts dropping down after 35, your BMD is so high that at 70, your BMD is still 50%. So that is why your fracture risk decreases. So we can consider osteoporosis as a childhood disease. So you start educating people from their teenage or younger age.
So the modern lifestyle challenges, what we will tell, if the children is following the new modern lifestyle, then there will have a low BMD and there are a high risk of osteoporosis in future.
Absolutely right. And the junk food.
Junk food, exactly. So awareness towards the junk food or a lifestyle is a one part, but indirectly it is going to make sure that they are good at strength with a lot of strength in the when they ages.
Now, shall I answer? There are a few questions here.
Yes, sir.
So,
Yes,
the
sir.
first question Mr. Abhay Kumar has asked in osteoporotic spine patient, when do you prefer starting teriparatide? Preoperatively and how many weeks before surgery? So, suppose it is a planned surgery. I have diagnosed that this patient has got -3 BMD or -4 BMD. We at least give 3 months to 6 months therapy before we subject them to surgery if it is planned surgery. So same thing can be done for the even the knee replacement or the hip replacement as well. The same challenges are there for the bony surgeries. So that is the answer. 3 months at least, maybe 6 months. In osteoporotic spine patient, okay. Do you see the better pedicle screw purchase and fusion rates with this teriparatide? Certainly yes. Certainly, yes. We do see even After we have seen the screw loosening, suppose patient has got osteoporosis, not treated properly, not managed properly, and we start teriparatide, and the bony fusion occurs, the screw grip also improves, the back pain also disappears. So this is something which but then we tell them to keep the patients, we educate them that it will take at least 2 to 3 months after starting the teriparatide. I came across a case of 12-year-old girl operated for sarcopenia, no bone metastasis, severe osteoporosis. Can denosumab be given? Yes, that's the ideal drug of choice. It's not recommended for the pediatric use. I think there are exceptions for certain things. So if it is osteoporosis, then probably one can give denosumab. In which spine case do you consider teriparatide mandatory? Burst fracture, failed fusion, severe osteoporosis. Mandatory is severe osteoporosis, burst fracture in somebody who is elderly, and failed spine fusion probably at any age. You know, many surgeons, we as a surgeon, we do not want the failure of our surgery. So most of the time now teriparatide is loosely used by many surgeons. And that is where I request, if at all you start, please continue for 12 to 18 months. And then afterwards, in order to have the sustained effect of teriparatide, we really need to tame down the osteoclast, and that is where we need to switch over to anti-resorptive therapy. Good evening, sir. This is Mahendra Bhosle from Pune. My question is, patient serum creatinine is 2 and patient is suffering from CKD. In such condition, which is best treatment to start? Now, for the CKD, denosumab is ideal. But if patient is not affording, patient may not take it, then you can say half the dose of bisphosphonate. And I think usually we refer to the nephrologist. It's most beautiful segment. Thank you. Thank you. And myself, Bharat, BS, do you avoid denosumab if patient is planned for major spine instrumentation? Practically, no, it is not. We normally do not say that, we avoid giving denosumab for the major spine surgery. But yes, somebody who undergoes a dental treatment, many a times the dentist, they advise to stop denosumab or bisphosphonate for that matter. Sir, I think all these questions I have answered. My email ID is there, so you can question, if there are any questions left afterwards. Over to you.
Hello, sir. Good evening.
Good
Sir,
evening.
there is another question that I would like to ask. Sir, in advanced CKD, because one of the during my field work, one of the doctors have asked this type of questions. In advanced CKD, stage 4 and 5, what is the optimum calcium vitamin replication protocol before denosumab to reliably prevent severe hypocalcemia?
Yeah. So hypercalcemia is quite common.
Yes, yes, sir.
And so that is why we really need to, give them the medicine to reduce the calcium first. That is one. Second thing, we really advise them to reduce the dose of bisphosphonate, but denosumab can be given. So many a times when we ask our nephro friend, they say you can give denosumab, that's not a problem. And we really advise them to give denosumab, and we are happy with denosumab. I have not seen major issues related to denosumab and CKD. But in high CKD patient, those who are really at the end stage of CKD, usually they can be given yearly denosumab rather than 6 monthly denosumab.
Okay. Okay. Thank you, sir. Thank you so much. It is a really nice session because when we launched Denosumab, that time, what we think, what will be our positioning for this brand. But today's session, we got a lots of clarity about this session. Thank you, sir. Thank you so much. Over to you.
Sir, which patients we should avoid either denosumab or teriparatide, sir?
No,
Is it?
teriparatide I mentioned.
Uh,
Those who have PTH level, which is high. Suppose somebody who comes to me has got a fragility fracture and I have done the PTH level. Now, if PTH level is high, then a more than 3 figure, more than 100, then I would look at the secondary cause of osteoporosis and secondary cause of hyperparathyroidism. And once I have done the secondary causes, if they are all normal, then I send them for PTH scan. Hyperparathyroidism, parathyroid adenoma is one of the cause which will give rise to osteoporosis as well, and PTH level will be high, and you are giving them teriparatide. So that will lead to more disastrous effect. So that is why we should not be giving them. So PTH level has to be checked. That is one. Malignancy is second thing which I mentioned. The reason why do we avoid malignancy? Because the cells may have the receptor.
Yes, sir.
So this is the reason why we do not give. For the denosumab, practically there are no as such major contraindications. I repeat only one thing: cold chain has to be maintained all the time, which is very important. The minute the cold chain is out, then it will become water.
Any comorbid conditions that we need to worried about while if considering treatment for denosumab or
To me again, probably renal failure. We can always ask the nephrologist, but most of the time nephrologists are happy about continuing the denosumab therapy. But if you have to give denosumab, and if the fracture occurs while patient is on denosumab, and we tend to start teriparatide, at that time we need to protect, because that window of 1 or 2 months, by the time teriparatide takes over, osteoblastic activity starts initiated, there is a gap where the BMD decreases, and that is where the fracture risk increases.
so then bisphosphonate and teriparatide to be started together, sir. That
It
time.
can be, it can be given. It can be given. But again, bisphosphonate teriparatide, that's usually not a major issue. But with denosumab is such a strong rankle, inhibitor. So it's really suppresses osteoclast to a great extent. And that is where, the negative side. Some of these denosumab have a lot of, social media. One of the American had really announced denosumab is something which is, pharma, these, that. So all these things go on everywhere, social media. But we usually ignore, we educate the patient.
Okay.
Uh,
Okay.
Sir, sir, can I come in? My last question to you, sir.
Yeah.
As far as the awareness of osteoporosis is concerned, the post-menopausal osteoporosis is still not highlighted in a big way. What we feel when we are talking to gynecologists, sir, can you give us some advice so that we can talk regarding post-menopausal osteoporosis in a big way?
Uh, that is where our discussion started with Mr. Vasu. We thought that we should be doing this more frequently. So I request him to wait for maybe few more months, because next year I'm becoming president-elect of ASSI. So I have taken the pledge that I will educate each and everyone in India, even if given an opportunity. So I'll be here, there on the post for 2 years, president-elect for 1 year, and then president for one more year. So at that time, I'm planning to initiate, and we can go to connect societies and we can educate them, and then we can take it from there as well. But yes, you are right that the awareness is not as much as it should be. And I tell you, the overall aging population is increasing so fast in our country. We are going to have a real challenge, and we do not have enough resources, enough rest homes, enough public places where patients can be treated best. So this is very important. But yes, we need to really work together.
Is there any thought that we can think of creating a ecosystem where spine visits gynecology hospital once in a month or something like that to make sure that this postmenopausal osteoporosis patients are seriously taken care?
I think the best way would be if we can have a gynec society and we can come with this drama and few patients.
Mhm.
We can bring in the patients, and we can have the osteoporosis, and we can tell them that this is just a drama, you come over, and we can have 50, 70 those who are really interested, and they should be invited. But then they should be invited in such a way that they do not skip at the last minute, because in the current situation what happens most of the time, that you are inviting somebody, you spend all the time, you spend all the efforts, and they don't turn at the last minute. So let's not have that happen. So if you have even group of 20, 30, then also it is enough, because then we can give them the educational activity, we can have the drama. But drama, like as we did, we invited them, we gave them the pass, we gave them the numbers as well. But then that was planned at least a month in advance, so that they can see their calendar, and then they can book the seat as well, and then we can take it from there.
So
But then
next year, All India Foxy conference is in Surat. This
yeah,
January, coming January.
yeah,
So this is like there will be like at least 10 to 12,000 gynecologists are gathering together. So we can think of presenting this drama during that conference to get the attention of gynecologists and seriousness towards osteoporosis.
please do that. I will be
Yes.
there. Please do that. I'll be there. What dates are in January?
I think it is a 9th, 10th, 11th, something like that,
That's
sir.
fine. So our ASSI is 3rd week of January. So first week of January is okay for us, for me.
Yes. Perfect, sir. Perfect. So I'll have a word with them, organizing team,
Yeah,
and we can have this scheduled program during the time then.
yeah, sure. And suppose organizing team does not support you, have a lunch symposium. Let people come and have the lunch symposium. And if they are happy, then we can have it second lunch symposium as well, something like that. If they
Yes,
if
sir.
they
Yes,
if
sir.
they give us 10 minutes of this drama, even that will be done as well. We can do that because this was only 3 minutes, but we can have the little bit bigger, rather
Yes, sir.
long.
6th to 10th, sir.
Yeah,
6 जनवरी से लेकर 10 जनवरी.
that's I'm okay with that.
Perfect, sir. Perfect. So sir will be there with us in Surat for
Sure.
ASD.
Yeah, sure.
Yes. So we can, if anyone want to ask questions, you can unmute yourself. You can ask the question directly to the sir, and you can also open your videos. Now you can free to share your
Please
questions,
ask
anything.
anything if you have.
Mm.
Basu sir, the most important thing sir has shared with us is the adherence to the treatment of teriparatide. Sir
Yes.
has correctly, in fact, guided us that instead of giving 4 months in one go, at least if we give them fresh vial month-on-month basis, then possibly there would be more chances of getting this. I mean, uses of this drug can be more effective if we give them at least month-on-month basis. Usually, what it happens that in most of the patient, it's okay, but keeping that in the fridge, sometimes if the fridge does not work or maybe something happens, then possibly the same quality of drug may not be administered. So it is advisable, sir has rightly suggested us that if it gives him month on month basis, that is okay. That will be more effective. And secondly, what sir has said, that doctor must aware and make sure, tell their patient that you must continue your treatment, don't stop it. It's must to continue at either with teriparatide or maybe with denosumab as per the desired therapy month. It's very essential. And most of the time, what we see that usually doctor recommend it for 3 months, and usually patient don't continue with more than 3 months. And even without consulting the doctor, they stop the treatment also. So that is quite important. Thank you so much, sir.
Thank you.
We have something, an interesting story also, like one of our medical representative in Mumbai who used to deliver teriparatide to the patients. So the patient initially, she's like a bedridden kind. And when initially the patient has taken teriparatide for 3 months and then he was okay, then he called the patient, patient called again for a next dose. So initially the patient is a bedridden. After 6 months, when the our MR goes for a next injection delivery or something, so patient is sitting on the bed. Then he has seen the serious improvement in the patient in such a way, bedridden patient sitting on the patient and patient coming to the door and opening the door for an MR, and the kind of improvement. MR thought that she's such a old and such a sick person, so I'm delivering this product, I don't know what use she will have, kind of this. Then afterwards he has got a serious respect towards the product, that how that makes the impact in the patient life, and he has conveyed the same message to the doctor and asked the doctor to have a word with that patient, and doctor was so happy that, so you made that kind of impact in the patient life by regularly supplying the product. That's the one thing. And he is happy that the patient has recovered well
Yeah,
post fracture.
So that is why we call it a miracle molecule, na?
Miracle molecule.
Miracle molecule. We call it a miracle. It just changed the practice. At Stavia, we use it extensively and it has changed the practice completely.
In the ASICON post your session, many of the spine surgeons are also discussing same thing. Like a Bharat sir has treated last 3 years, I think, all spinal fractures without a surgery and operating with the surgery. So he just simply continued the patient with the denosumab and teriparatide kind of medication, and he has stopped doing surgeries, kind of this thing. There's
Yeah.
many doctors were shared that discussion with us.
Yeah. So, vertebroplasty is obsolete method now, obsolete way. But that is something we know. We keep sharing.
Okay.
Okay.
Anyone else want to have a question to ask the sir?
Yeah, good evening, sir.
Good evening. Good evening.
Hello.
अनुज भाई पूछिए.
Good evening, sir. Sir, one question I want to ask, sir, do we continue the teriparatide in post-operative patients, and for how long?
Now, ideal dose of teriparatide is 18 to 24 months. Then afterwards, we need to switch over to sequential therapy. So we start from teriparatide and switch over to either denosumab or zoledronic acid or alendronate, whatever. But it has to be continued. And I repeat, it's a lifelong disease, so you have to continue.
Okay, sir.
Basu sir, good evening.
Good evening. Puchi.
Basu sir, actually, one incident is already I'm facing in my family. My mother is already suffering through osteoporosis. I have already given a suggestion from a good orthopedic surgeon, but he has told me that firstly you go through the teriparatide for 3 months, then you go switch over the denosumab. But without giving the teriparatide, I have given the denosumab. So I need to get information from sir. Can I switch over between the first and second dose of denosumab? Can we switch in teriparatide?
No. Now, I think you do not switch over to teriparatide. Continue to treat with denosumab and continue. Do not stop. You may add vitamin D, calcium. I'm sure you must be giving that. And you may add the decadurabolin for sarcopenia. So these are the things which we should give. But as you have started already denosumab, don't worry. Continue denosumab now. Now switching over to teriparatide will be harmful, as I mentioned. So the cellular mechanism will have imbalance. So let's not do that.
After a single dose of denosumab, I have got a very good result, sir.
Yeah. I think, I repeat, these are the molecules which we really need to take care, but it has to be continued. This is the most important message I want to give. Has to be continued.
Sir, but you have told it would be
Sorry?
Teriparatide first
continued
and
up to
then
2 years.
No. In a severe osteoporosis case, in a fracture patient who has got the fragile fracture, that is why I put the classification first. Moderate risk, high risk, and low risk. So moderate and high risk should be given with anabolic first. In the low risk patient, you can give denosumab directly or zoledronic acid anti-resorptive directly.
Actually, she has been already hip transplant.
Yeah, fine. Hip transplant was done because of the hip fracture. I repeat. Am I right?
Sir.
Yeah. So then she's already has had one fragility fracture. So we should be giving. But now since denosumab has already been started, so don't change over now.
Okay, sir. Thank you very much, sir.
Yeah.
Vasu, 1 minute. I would like to speak.
Yes, sir.
Sir, my name is Vijay. I take care of all the businesses of Corona Remedies. So really nice listening to you. I was there right from the beginning till the end. And one thing which came again and again in your talk was the pharmaceutical industry, Indian pharma industry, in two aspects. One is the Indian trials, which I think Vasu and team will really work on how to get more number of Indian trials done through RWEs. And the second thing, sir, is the cold chain management. Let me just give you the clarity that as a company, we have a robust cold chain management system, and all our injections, which are 2 to 8 degrees, go through this cold chain management system. And till the patient gets it, even we have a patient consent also saying that they can see the temperature as 6 degrees or 5 degrees inside the box. So that ensures that from the factory to the patient gets the cold chain supplies very well. And we also instruct them that they should not use it without refrigeration. So that also is one thing which we are doing it on our, because we sell gynac injections as well, like the
HCG, HMG, FSH, all those hormones. So actually, Corona has got a hormone expertise tagline globally. So we are we call ourselves as a hormone expert. So we are very well managed as that cold chain system across the place. And even in our distribution system, sir, we have a very strong compliance policy that our distributor is not having a cold chain facility. It will not be billed to the stockist, and the distributor will not get the stock. So system is already marked. Our logistics has already marked. who are all the distributors, means among the 2,500 to 3,000 distributors who are associated with us in our business, and out among that it's like around 1,100 or 1,200 distributors who are marked as a cold chain facility distributor. So they are the only one who has supplied this, irrespective of the whether they are doing business for 100 products, it is okay, but cold chain products they will not be supplied to them.
That's great. That's great. Good to know this, good to know this. So these are the things, should be percolated to a consultant as well. This is what is our criteria. Because those who are treating osteoporosis to the level which we treat, if we have given this information, okay, this is what our cold chain criteria. Then another thing which you may share tomorrow or other later, whenever. So this many samples did not maintain the cold chain, and that's why they are discarded. This is something which is very important, because that's the information as a consultant. I would say, okay, oh no, Baba, you have done this homework and this were the one. Because what happens, what I see some on occasions, that it will be going to somebody if it is not maintained. So that is the main worry, because that's why I put the word time bomb. You have to have the first 3 months are very important, very crucial.
One injection go with the good cold chain and second injection doesn't go with the cold chain. It has got a serious impact on the patient.
So you got my message,
Yes,
so that is something which I did not elaborate, because it doesn't look good from my end to
No,
talk about
it is absolutely yes, sir. Because in IVF concern, like each supply box will have a usually temperature tracker default.
Yeah.
Because they take like 100 injections, 50 injections of HCG, HMG, FS, all hormone. So that has got a box comes with the temperature tracker along with that.
Yeah.
So anyone else wish to share your queries?
Just Mr. Vashu, just to show you, this is the.
It's a very good one, sir. Actually, we will implement this to our team.
Yeah, that's right. So this is something, whenever I go for such talk, I usually go with the t-shirt. So, it makes people understand that the Eiffel Tower is being banned.
Great.
It's a very, your preparation towards the program is so in-depth, sir, today. Means more than the seriousness of our team who are joined today, like 800 people who are joined today for the program. So entire MR and area manager team, they have joined through our Maitri platform, Corona's platform, which has got a capacity to accommodate at 50,000 participants at one go. That's the one thing. Then all senior managers and above, RSMs, regional state heads and above, they have joined in the Zoom directly.
Thank you.
So
Sure.
we'll have one more session in continuation to this, like
Sure.
to the team, so that they will be more empowered and more confident to discuss. Because if today they have one question from the consultant, they will keep quiet.
Yeah.
So this will.
I can start with the examples, because
Okay.
today I did not include examples, because this was basic thing which I wanted to narrate first, because I was more concentrating on the therapy. So that's why I put this pledge word and all that, because I'm more worried about supply has to be proper, and indication has to be proper, and the dialogue to the consultant has to be perfectly timed, so that when you introduce something, so usually if I am as a consultant, do I have time to read for everything? I usually follow, what's been talked with the MR. But then, yes, at our level, we certainly discuss in our group and academics as well. But sometimes, many consultants, they don't. And then they will follow what's been advised, what's been discussed with the MR call. So that is why I was very, very, pertinent about this. No, this has to be talked. This has to be discussed. This has to be, openly shared. That once you start, do not stop. Or if you stop, you change over to other molecule. Okay. Thank you. Thank you for giving me the opportunity.
Thank you so much, sir. I'll try to compile the other questions which has been not shared today or something. So I'll share it in a one single mail, so that either we can plan next session based on that, or you can help us with your views on the same, either of that.
Sure.
So pleasure connecting with you, sir, today. And whole family of Corona is like thank you for sparing your time because we know your schedule, we know your time. But in spite of that, one promise that you have given to us during that ESICON discussion, and you said that I want to share the insights to your team. So this is really inspiring to us, and more than that, we need such kind of educational support from you and guidance from you. So because as an organization we are moving so strong with the orthopedics in continuing our academic journey and the scientific approach to the society and to the doctors fraternity, are those concerned, are those fine and all together. And definitely we'll continue this program again, sir, based on your schedule availability.
Sure. Thank you very much. Thank you.
Thank you so much, sir. Thank you.
Thank you. Bye.
Thank you all heroes for joining.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you.
For closing and Denosumab, mainly for Tricham Active.
Thank you, sir.
Availability has been made to fullest. Okay, team, all the best. All the best.
Thank you, sir.
बढ़िया बढ़िया चारू भाई, अच्छा समझ में आ गया ना?
हाँ जी सर।
ओके, हम समझ गए।
बढ़िया बढ़िया महेश भाई, अभय भाई.
And also stock is there of Denosumab in every place. Stock is available now.
राहुल भाई, भारत भूषण आपका हो जाएगा.
हेलो.
चलो भावेश भाई, धन्यवाद बहुत बहुत.
మీరు వీటికి వెళ్ళిపోవాల్సింది ముందుగా.